Welcome to A&MC Nursing Grand Rounds. There are no disclosures, financial disclosures for this program.
All right, so first of all, thank you for taking time out of your day to join us to chat about end-tidal carbon dioxide monitoring and waveform capnography. So just a quick introduction from myself. My name is Brian Fakes. I'm the manager of respiratory therapy here at A&MC. I've been here since April, so still getting my feet wet, I guess, in some ways. But one of the committees that I belong to here is the resuscitation committee. So Julie and I work together on that. And really the idea for this topic came up after reviewing a number of code sheets where there was missing documentation of end-tidal CO2 on those. And it's an important parameter to monitor, and we'll go through during the course of this presentation, we'll look at some reasons why monitoring end-tidal CO2 and having an understanding of what the waveforms are telling us is so important, particularly in cardiac arrest situations. There's a variety of other applications for monitoring end-tidal CO2 and capnography, but we will spend some time focusing on the cardiac arrest aspect of that. So, Julie will be interjecting from time to time too. We're going to kind of co-lead this, but the first thing I wanted to do too is we can just go around the room because I know there's a lot of faces that I don't know. If you could just say your name, first name, and what unit you work on and what your role is.
Shannon, CCU.
Kathleen, ED, staff.
Julie, ICU staff.
Tony Lockwood, Central Nursing Office.
Carol, Five East. I'm Tasha, I work in clinical education with Jen. And I'm Jen from clinical education.
Okay, cool. Well, welcome everyone. So let me see here. Sorry, I'm going to be walking back and forth here a little bit, just advancing slides. Okay, great. So my vision for this presentation, I want it to be kind of informal. So if you have questions about things, just jump in, ask them. I want it to be kind of an interactive process. I don't like listening to myself just talk for an hour. So the game plan is going to be, there's about 15 slides here I think that I have that will go through kind of the process of monitoring end-tidal CO2, what it is, get into some of the equipment, and then we're also going to leave time to have a hands-on portion. So as you can see, we brought a lot of fun things here to play with. But really the purpose of this is we want you to have an understanding of what end-tidal CO2 is, why we monitor it, but then also be able to have some clinical application with that and understand all the different ways that we are able to monitor those things and then how to actually use them. So I'll be talking for a little while. We'll spend some time going through the equipment and then leave some time for questions and answers at the end. So first of all, the important thing when we look at waveform capnography is just having a general understanding of what carbon dioxide is and where it comes from. So it's part of the process, we breathe in, we breathe out. Carbon dioxide is a metabolic byproduct of that process. So the body uses oxygen, so when we breathe in, oxygen enters our lungs. And it is circulated throughout our body. The blood picks up the carbon dioxide, takes it back to the lungs, to the alveoli, where it's exhaled. So carbon dioxide is a metabolic byproduct of that. So the heart circulates oxygenated blood through the body, diffuses out of the blood, where it's used for metabolic reactions at a cellular level. And this kind of demonstrates this on the slide. So you can see oxygen entering through the alveoli, carbon dioxide exiting, and then the process of gas exchange taking place at the end of the alveoli. Metabolic reactions produce carbon dioxide, that's where it actually comes from. And then carbon dioxide enters the blood where it's transported back to the lungs and then ends up being discarded through exhalation. Looking forward to the next one. Okay, so what is end-tidal carbon dioxide monitoring? So this is a non-invasive method of assessing 3 different things, so metabolism, ventilation, and perfusion. And all of those we're going to talk about individually as we go on in bits and pieces of the slide. This has been around in different forms for going on 30 years now, so really end-tidal monitoring got its start within the operating room and with anesthesia. That's really where it originated. Like I said, it's about 30 years old at this point, the process. So it was traditionally used to confirm proper endotracheal tube placement. Again, now it has several different applications. I'll go into each one of those individually, but it's interesting to see all the different things that end-tidal can help us with now. Two different ways of measuring end-tidal CO2. So you have a qualitative measure, which is so the calorimetric end-tidal CO2 detectors, which there's a picture up on the screen of them, but also one here. So this is the device that we use at our facility right now. And I don't know, everybody's probably familiar with this. I think everybody's probably seen that at one point. And then quantitative, which is a device that would provide us with a number. So that's an example on the screen there, which is giving you an actual digital readout of the quantity of end-tidal CO2 being exhaled. All right, and then we have waveform capnography. So that is a continuous numeric and graphic display of inhaled and exhaled carbon dioxide. So that example up on the screen there, you see the white waveform towards the bottom there. It says that the EtCO2 is 32 and the rate is 21. So that's where that capnography or the waveform piece of it comes in addition to the actual quantification of exhaled CO2. There's different ways, depending on the device, of measuring that and how it actually works and how it picks up that information. So there's infrared or IR spectroscopy, and that actually uses infrared light. I believe that the Zoll is one that operates with that principle. So anytime you see a cuvette like this that's attached to a cable, or this is another example, we'll go through each one of these individually, but the process of reading the end-tidal CO2, it's being picked up with infrared waves through this device right here. And it works well with carbon dioxide because it requires at least two different atoms to absorb those frequency waves. So oxygen, for example, because it does have two atoms, but it's both the same, they're both the same there. With carbon dioxide, because you have two individual atoms, it's able to pick up those infrared waves and then give us a readout of that. So the other options that you'll see too are, I put up there side stream or micro stream, and that's going to be the variety that plugs into our Philips monitors with this adapter right here. They can be different colors, they can be orange or yellow, but that monitoring takes place with an actual sample line. So what's happening is the gas is being exhaled into the sensor at the end of this, and then it's being fed through the sample line up to the monitor where it's actually being read there. So the process is a little bit different. They each have their benefits and drawbacks, and we'll go through some troubleshooting of each product individually and give you some ideas of if it's not working, things to look at in terms of troubleshooting it. So you can go on to the next one. So I think this is important. So the number that we get, or the actual readout of end-tidal CO2, it's important in dictating a number of things that we do, but understanding the waveform and what the waveform is telling you gives you much more in-depth information. So there's a lot more to it than just understanding what the number is. The waveform itself can tell you a lot about what's happening with the patient. So this, and we'll go through, there'll be just some different slides on here, and then we have some printouts here that look at actual waveforms and what the difference is and what you're looking at. But the first thing is I want to just make sure we go through and everyone understands what we're looking at in a waveform, kind of pick it apart. So there's three different phases to just a single waveform of capnography. So phase one is on the bottom left there, and that's actually inhalation. The reason it's down at baseline is because when you're inhaling in, there's no carbon dioxide obviously being exhaled. So you're breathing in oxygenated gas, then you're going to exhale CO2. So at baseline, typically your reading is going to be 0. There are some variations to that and some reasons why it may not be 0. But again, those are things that you should identify as not being normal, and it's usually because there's a condition that you need to address. So phase one, again, baseline. Phase two is where the rise is starting. So this is the beginning of the exhalation phase, when you start to breathe out. The first part of breathing out and exhaling CO2, the first thing that empties is called dead space. So anatomic dead space is what exists within your nasal cavity, within your mouth, your oropharynx, hypopharynx, down to the trachea, and then both of the main stem bronchi on either side of your lungs. So it's areas where there's not alveoli participating in gas exchange. So those areas where there's not any CO2 are going to empty out first, and therefore your reading starts low before you move into phase 3, which is that plateau kind of up on the top there. And once you start hitting that plateau in phase 3, that's all the carbon dioxide gas that was down inside of your alveoli, and that's the carbon dioxide rich gas that then starts to interact with the sensor as you breathe out, and that's where you start to get that plateau. And where that green area is circled there, so that's where your actual end-tidal carbon dioxide reading is coming from, which is the end of exhalation. So that's why it's called end-tidal. So as the last part of your exhalation phase, that's where it's picking up the end-tidal reading from before you take another deep breath in and resets the waveform back to 0. Okay, next slide. And if you guys have any questions, just interrupt and jump in. There's a variety of ways of interpreting waveform capnography. One that I came up with, it's called PQRST. You'll see a variety of other things that'll walk you through the process of looking at this. It's just like anything else where you're reading an ECG lead, there's a way that you look at that. Or reading a chest x-ray, there's a method to actually doing it. That's just one of those suggestions to look at it and making sure that we're catching everything. So the P stands for proper. So proper is understanding the normal readings for the quantity, rate, shape, and the trending of the EtCO2. So the quantity, I keep saying quality for some reason. Quantity is the target CO2 value for an adult patient, which normally is between 35 and 45. So that can be either high or low for a variety of reasons, but the normal end-tidal CO2 value is 35 to 45. Rate, typically for an adult, is 10 to 20 breaths per minute. So end-tidal CO2 reflects slow or quick ventilation. So whether you're hypo or hyperventilating can mean different things. That should be something that would stand out to you when you're looking at the waveform capnography. The shape should be rectangular with rounded corners. So that is a normal waveform that we're looking at there. And like I said, in the next couple of slides, we'll go through what abnormal waveforms look like and then talk a little bit about what they mean. And then lastly, the trend. So that is the quantity, the rate, and the shape of end-tidal CO2 that should either be stable or improving. And like I said, they'll take on all different shapes and sizes. So. All right, so this is some examples. So we just looked at that previous slide that looked like a normal waveform. So these are some examples of abnormal waveforms. And if we want, we can pass out these, and you guys can look at these too. Because there's some on here. Yep. Do you guys have one on that side? So these are some more that I don't have up on the slides, but it kind of gives you an idea of what you're looking at when the waveforms are abnormal. They can be fast or slow. I think there's some examples on there of hyperventilation, hypoventilation. This example up here on the monitor, so 4A, which is the top left one, shows apnea, what apnea looks like. So obviously there's not much of an upward inflection, which indicates that the patient is not breathing. So that was part of that, that PQRST process was the rate. So obviously there's no rate there. It's not a rounded rectangle. There's basically no form to it. 4B can be from a variety of reasons. Anytime you kind of see that shark fin, it's usually indicative of some kind of obstruction, whether it's mechanical obstruction with secretions or something physiologic. Like you'll see that with asthma patients, COPD patients. Typically, there's signs of obstruction in that sort of shark fin shape when you look at end-tidal capnography. 4C is normal, so that was, again, that's normal waveform. So if we've just responded to a cardiac arrest up on the floor and we've intubated that patient, typically you'll see these used, the colorimetric end-tidal CO2s. But when we switch over to waveform capnography too, you expect to see a normal waveform like that. If you don't, It can either be that the patient was intubated in the right mainstem bronchus, which happens from time to time. So it could be just that it's independently ventilating one lung. It could be that there's obstruction in the ET tube. There's a variety of reasons that can cause it not to look normal. Esophageal intubation is another one where you pretty much won't see anything. And then 4D is another example of that along those lines. So sudden drop. If you've had good end tidal reading and good capnography, and then all of a sudden something like that happens, that should draw your attention to it, because that can either be apnea or dislodgement of the tube, patients going into cardiac arrest. There can be a variety of reasons for capnography where you've confirmed it and it's been a good waveform. If it all of a sudden disappears, that's something that should definitely grab your attention.
Would mucus plug be more like the shark fin?
Mm-hmm. Yeah, because it's an obstruction.
Mm-hmm.
So anytime there's an obstruction, you'll see that waveform usually takes on, instead of a nice rectangular type shape, it's going to get more of that shark fin type shape. So it can be from secretions or things like that, or like I said, it can also be physiologic things like, if you have a bad asthmatic come in, or a patient that has chronic obstructive pulmonary disease, a lot of times too, their waveforms will look like that when they're in acute phase. Okay, so equipment. So this, I don't know if do you want to do that part now, or just kind of go through the slide and then we can
I
do
think
this
let's
afterwards?
go through all your slides and then we'll
Okay, perfect.
get people up.
So we'll talk a little bit about this as we go through these individually, and then once the slides are finished, then we can actually do some hands-on work with this and you can get a better feel for it. But I'll kind of highlight all the different things that are sitting on the table here just one by one and talk about a little bit about what they do. So different equipment for monitoring end tidal CO2 and waveform capnography. So the first one on there is the colorimetric end tidal CO2 detector. So these you see all the time. They're usually either purple or blue at the end at baseline. It just depends on the manufacturer of the device. But like I said, these are the ones that we have here. So the easiest way to remember it is yellow is yes. At baseline, they're either going to come blue or they're going to come purple. If you see either one of those two colors, it means that that's not being exposed to carbon dioxide. Once carbon dioxide passes across the sensor here, it's going to turn yellow, regardless of what the device is. Yellow is sort of the universal color of confirmation of end tidal CO2. The next one, so the Philips monitor is over here. We also have these in the intensive care units where there's a separate module that will plug into the monitor that you're able to monitor end tidal CO2 with. But these use that side stream or microstream technology where it actually is an adapter that plugs in, and it has that sample line that's attached to it that's drawing gas into the monitor to be read. So that works with a variety of things. So right now the one that I have attached to it is a nasal cannula, and we'll play around with that in a little bit. These we actually don't have at the facility right now, but the reason that I'm showing it is just, it's an option. People will ask, can you monitor end tidal CO2 with a mask? And the answer is yes, if you have the right equipment for it. That technology does exist. This particular mask is made actually for endo procedures. It has that opening where you can feed scopes through it, but anything that requires procedural sedation, like a lot of endoscopy stuff does, it's actually really a nice option that's useful for monitoring that, providing oxygen and also being able to accomplish the procedure.
Is that for a Philips monitor?
Yep, this is also, I don't think it's proprietary for Philips, but the adapter does work.
Okay.
They're portable, that's the other thing, the monitors are portable obviously. The non-invasive cardiac output monitor, so that's called the NICO, so that's this device. And I know that you see that in CCU. Anybody who works in PICU, they'll also see that, but I think those are the only two clinical areas right now where NICO is being used. And this gives us a variety of information. It's not just end tidal CO2, it's a bunch of other stuff. I actually calculate cardiac output and some other things. So yeah, a lot more to that device, and that's the reason why you see it typically in the critical care units here. This requires an invasive airway. So you'll see this one's attached to an endotracheal tube. We have the Zoll set up that way as well. But some of these, it actually requires an artificial airway. Zoll monitor sitting here, you guys are probably all really familiar with the Zoll. There's a way of monitoring end tidal CO2 on that as well. requires activating that parameter. I don't think that our model, there's a bunch of different models for the Zoll, and some of them are interchangeable where you can plug in the side stream monitoring to them, but it's a different attachment that comes off of here. And I don't think that we have
We
those.
don't have that.
And then I don't think ours does waveform capnography.
It does not do,
Okay.
it only provides a number.
Got it, okay. And then there's some of those, like I said, it just depends on the variety, but I know Zoll they make monitors that you can actually do capnography with. So those are also portable. And then the last thing is the IV pumps, and I know that that technology exists, but again, do we
It is
have
not
those?
implemented yet here, it is on the horizon.
Okay, cool. All right.
Are Zolls gonna be updated to do,
All our Zolls on campus do end-tidal CO2 now.
but just not the waveform?
Correct, they only picked a number instead of, because we'll go over it, the box is so small, we would not, you know, you need a strip
Right.
to actually see the waveform, and it's so small, they decided only to go with a number.
All right, so
But on your Philips in the ER, you
Mhm.
have the waveform.
Yes,
So you have the ability
to still.
to trauma 1 and trauma 2 with the Philips, and then you have 3 Zolls, so you have the ability to do 5 different end-tidal CO2 stations.
all right, troubleshooting, because of course, everything doesn't work perfectly every time. So it's good to know some steps to take if for some reason you plug this in and it's not working, or if it was working and then all of a sudden it stops working. So troubleshooting the equipment first. A lot of times it's as simple as on these, and again, you'll get some hands-on experience with this, but there's a cuvette that's attached to this. So this plastic part detaches from the actual monitoring element of the Zoll and also on the Nico. If this isn't snapped in all the way, it can cause the reading to stop picking up. There's a very difficult to see arrow on the end of this plastic cuvette here that again, you guys will see when we start playing with this. But there's also an arrow on the end of this device. And if the arrows don't align, it's not going to give you a reading. So it's really important to make sure that those are lined up the right way. The system purge for fluid in the sample line or the device interface. So all that means is when we're using these with that side stream technology, if it's being plugged into a Philips monitor, whether it's in the ICU or somewhere else, it's very easy for the sampling element of this to get filled up with secretions. Or on a ventilator circuit, there's a lot of condensation that's produced within that. So whether it's condensation or secretions, it can start gumming up your sensor. And instead of pulling air up the sample line, it starts pulling secretions up your sample line. Once that happens, everything's going to shut off. You're not going to get any numbers. Some of the devices will actually tell you that the filter line is plugged and then you need to change it. So some of them are smart enough to tell you that. Other ones you just have to recognize, you know, when you see a flat line that it could likely be secretion related. The system could be auto-zeroing, so that happens from time to time too, just when it resets itself. And then when a shock is delivered. So if you're using the Zoll monitor, I think that on that paper, there's a graphic display of that on the bottom right of that. That shows you what happens when a shock is delivered with the Zoll. And it actually creates a system reset. So you'll see the end-tidal CO2 typically quickly drops to 0 and then it will rebound back up. Another useful thing to troubleshoot that happens from time to time is loss of airway function. So what does that mean? We talked a little bit about improper placement of an ET tube. So the most common is esophageal intubation. So when we place that tube initially, if we're not getting carbon dioxide exchange, it's probably because the tube is in the esophagus instead of in the trachea. It can also alert us to when the tube is dislodged. So if the patient's moving around or not secured properly, numbers change a little bit. If this slips out of the trachea past the vocal cords and it's sitting in the hypopharynx, you're going to see the numbers will drop off. It'll also alert you to endotracheal tube obstruction, and that's kind of what you were saying, is if there's secretions in there, not only will you see your waveform change, but occasionally too your values will drop off or disappear. There's also other physiologic factors when it comes to troubleshooting. So these are some things that will cause your waveform to either disappear, become dampened, or just take on a form that's not normal. So apnea, again, expect to see something that's mostly flatline with that. Pulmonary embolism will cause your carbon dioxide level to drop significantly. Exsanguination without adequate perfusing volume, you can see issues with that and carbon dioxide drop off or disappear. That's one of the things, I know that you guys don't work in pediatrics, but if we're resuscitating a neonate, a lot of times you can place an endotracheal tube and visualize it going through the cords, but when you put a color EtCO2 detector on the end of the tube, it may not register anything right away. And it's not that the tube isn't in the right position, it's just that in a cardiac arrest situation, there's not enough perfusion to actually generate a CO2 value. So that's just one thing that I'd exercise caution with. I see that a lot where ET tubes are placed and then they're removed because of a value that's being given to you on here, when the intubator's actually seen it pass through the vocal cords and it's just a perfusion issue. So just be mindful of that. And then inadequate CPR, and we'll talk a little more about that too in the cardiac arrest section, but if we're not adequately providing chest compressions the right way, we're also, it's going to affect our end-tidal CO2.
So these would all be more like the, where it looks like the apnea, with the pulmonary embolism,
The pulmonary embolism, it'll typically be depressed but not zero. The values will be a little bit lower, but it shouldn't be zero or baseline.
so it might be like it's normal and all of a sudden we're seeing it lower.
Right,
That might be
and it will be, if it's a PE, it's usually sustained lower too, until it's addressed. Okay, so these are some options. So when would we use end-tidal CO2 capnography? The big one is cardiac arrest, and again, that was the big driver for us putting this presentation together. And we'll spend the next 2 slides talk exclusively about cardiac arrest situations. Airway assessment and mechanical ventilation. So airway assessment is, again, confirmation of endotracheal tube placement. In a cardiac arrest situation, I think I talk about it on the next couple of slides, but I just want to mention it also now. If you have a patient that has an advanced airway in place and they code and you're now doing chest compressions, it's still a good idea to verify that the tube is in place. And that's something, again, you know, I think that's something that is maybe omitted from time to time, that we just assume when a patient codes, you take them off the ventilator, you attach an ambu bag to them, you start ventilating them assuming that the tube is in the right spot. But we still need to verify that it's in the right spot.
You need to verify it and also document it. So the documentation on the code sheets is end-tidal CO2 confirmation. And that's by the colorimetric, and then continuously with the ZOL. And that is recorded as a vital sign, Q 5 minutes or Q whatever, how many. Sometimes we take vitals faster than Q5. So if it's 3, we want that end-tidal CO2 recorded on the code sheet.
So like if I got somebody in coding by EMS, y'all's recommendation is to still pop on a little CO2 before we start back?
Or you can use quantitative.
You could just go straight to quantitative. You don't have to use a colorimetric.
Okay.
One or the other.
Just as long as it's documented that we see a waveform and then we're seeing the number.
Yes.
Yeah. So the number is basically what we would document?
Correct.
Okay.
We would go by the number because we can't drop those waveforms.
Right.
And it's all right here on these sheets.
I'm just wondering where we're not writing that.
So where
it's
we're not writing
interesting.
it is right in here.
Okay.
And then,
So just- For, just for education in the ED, just to make sure that
and then
they're writing
the
it.
confirmation is right here on all the way down on both sheets.
So we just keep confirming by writing that. I think
Yes.
they probably write that, and maybe they miss it here?
We miss
Or
it up here more
here.
the most,
Okay,
but we miss it both places.
okay.
And it's challenging because the RT's at the head of the bed and oftentimes the Phillips is right here. So we all need to remember to call that number out for whoever's recording it. Because it's,
Do you coach your respiratory therapist to be looking for that and
So we've-
making sure that's priority in the code?
Yep, so we've been trying to pass that along and the importance of it. It's good for everyone, again, the more reminders the better, but the reality is, like Julie said, and I actually touched on this in a slide that's coming up. In a cardiac arrest situation, typically the RT is at the head of the bed, managing the airway or helping manage the airway. And frequently, at least down in the trauma rooms, in CCU, the monitor is going to be right here behind them. So they're going to be looking down at the patient, making sure that they're ventilating properly, doing their piece that way, or
And
either
getting
performing
chest
intubation or helping with the intubation. And yeah, they're not going to be able to keep looking behind them at the numbers. If it's a color, if they're using the colorimetric CO2 detector just to confirm airway placement when a new airway is placed, they should be calling that out to the group. But when it comes to the actual vital sign checks and recording of end-tidal CO2 and looking at the capnography waveform, typically that's going to be behind them and they may or may not be able to see that from where they're positioned at the bedside.
So it says confirmation, exhaled CO2, that's our colorimetric.
So it can be either.
It can be either.
They can call out confirmation when they see this change to yellow after they start ventilating, or if they hook up, if they're hooked up to the Zoll like this, and you start seeing a number registering on the Zoll,
So either
one
of
is
those,
confirmation.
we
Yep.
can circle that, and then direct revisualization?
So that would be with the laryngoscope and seeing that the ET2 passes through the vocal cords.
So then we also do, that's not on here, like breath sounds and then the x-ray.
Yep, breath sounds, x-rays, things like that.
That's
Just write
where
that
we
in.
would do it on that side, the comment area.
Do you guys have the numbered little one that you saw, the digital one?
No, and I wouldn't mind getting some of those. I think that there's some value in that just for a quick
One of
kind of
my
spot check,
previous
but-
facilities, it was the RT's responsibility to put that one, the numbered one, on the bag valve mask or intubated, because you're bagging them during the whole code, and they coached whoever was doing the quality CPR how well they were doing by calling out the number and saying go faster. But it was the RT's job to maintain the airway, keep track of the CO2, and coach the CPR.
If we had those devices, I think that it's a great
I think
idea.
that would be an
I think I like the
excellent
visual of not having to
implementation.
take your eyes off the patient, being able to see the value.
Yeah.
So down the road, again, depending on
Some-
cost and
I
everything
know.
else,
Okay.
but I think it's an awesome idea. But for the time being,
Right.
again, the purpose of this education too is, if the RT can't see the monitor and what they're looking at, the coaching is going to need to come from someone. And we'll look at some examples here when we talk about cardiac arrest, but you can look at that capnography and determine, ACLS says every 2 minutes you change compressors. You can look at the waveform capnography and say, all right, their compressions, the quality of their compressions is starting to deteriorate. Do we need to switch compressors earlier than 2 minutes? So it is important that somebody is watching it, whether it's the RT or it's the monitor person recording the monitor.
And this is all based on Get With The Guidelines, which is a national benchmark program through American Heart Association. And this is what every box on that code sheet is data collected for Get With The Guidelines. And we joined them 2 years ago this month. And the program has been in existence like 12 or 13 years. So, and it helps to do quality resuscitation for our patients.
All right, so some other uses of ETCO2 capnography. So we talked about the airway management. Mechanical ventilation can be a standard just to see how your patient is doing. Again, frequently, there'll be times where actually we'll use the NICO or use the Philips monitor for that. Procedural sedation. I also know, I came from Providence, it's the hospital I worked at prior to coming here, and they had a protocol. Any patient that was on a PCA pump was also on end-tidal CO2 monitoring, and they monitor IPI, which is a value of end-tidal CO2, pulse oximetry, respiratory rate, a variety of other things, but that's a very good use for it, to look and see if your patient's starting to develop respiratory depression or other airway disorders.
On the floors, we just have them on the pulse box.
Yeah, so it's, And I'm not trying to make, don't get me wrong, I'm not trying to make a pitch for, every one of these should be happening here. Some of them I think are more commonly accepted than others, but this is kind of a list of options where that could be of value. But when it comes to sedation or PCA management, it's actually it's a really nice option to keep your patients safe and make sure they're not being overly sedated. So pulmonary disease, like we talked about that, so asthma, COPD, bronchospasm produces a prolonged expiratory phase, which manifests itself on there's that shark tooth type waveform, or shark fin, sorry. Pulmonary embolism, so you'll get reduced pulmonary perfusion because of that blockage. It increases alveolar dead space, because if there's not blood flowing to the alveoli, that's what creates dead space when you have the gas but no perfusion along with it.
So it would be longer instead of more apneic, or less? it
Lower.
would be
It's also going to be lower.
lower and
It's going to
longer?
depress the waveform. Yep.
Mhm.
Heart failure is another one. So this one was kind of interesting. I didn't realize, it was actually a study when I was putting this together that I looked at this, but end-tidal CO2s of greater than 37 are rarely observed in patients that have heart failure. And that's one way that you can differentiate heart failure from a COPD type
That is
exacerbation.
interesting. Because it's 35 to 45, right?
Right.
So it's a little space for heart failure,
Yep.
and the rest would throw in the COPD.
Yep. So
That's
COPD,
very
you would
interesting.
expect your end-tidal CO2 to be higher, but it was interesting
Yeah.
that, and it's hard to
I like
differentiate
that.
the two sometimes when you're looking at a patient, but yeah, so rarely, apparently, if any, I actually think the study said there wasn't any cases observed where end-tidal CO2 is greater than 37 in heart failure patients, so something interesting. So shock, end-tidal CO2s can be reduced whenever you have volume-related hypotensive states. That's due to the decreased cardiac output. So end-tidal CO2 and cardiac output are tied hand in hand. The higher your cardiac output, typically the higher your end-tidal CO2 and vice versa. So in the presence of decreased cardiac output, you're going to have a lower end-tidal CO2. And that plays into cardiac arrest situations. Metabolic disorders, so there's a connection between end-tidal CO2 and bicarb, so it's a predictor of metabolic acidosis and also mortality. DKAs, so it's diagnosed when your end-tidal is less than or equal to 29, and it's because of hyperventilation. So patients that are in DKA, they're trying to hyperventilate to drive their CO2 down to compensate for that acidosis that they have, for their metabolic acidosis. So that's typically with them, you'll see the CO2 low. Gastroenteritis, so I know that this has been identified, at least in the pediatric population. I'm not sure how commonly this is being done with adults, but in the presence of vomiting, it can throw your bicarb levels out of whack, so it'll actually be picked up by end-tidal CO2. There's a correlation there.
It'll be, what will it show? I'm not following.
So the carbon dioxide and bicarb are tied hand to hand.
So it would be.
So it's a status of your overall acid base.
So it kind of correlates 35 to 45 with what your acid base is?
Well, under normal circumstances. So a normal end-tidal CO2 would be 35 to 45, just
Right.
like in a blood
Right.
gas, your CO2 would be 35 to 45. But in the presence of other issues, it'll either be high or low. But again, it depends on what your bicarb is doing. So if your bicarb's high, your end-tidal CO2 is either going to compensate or it's not, depending on what the process is.
Mm-hmm.
So it can be an early predictor of what's happening with your bicarbonate level. And then the last one is trauma. So low CO2 has a strong association with shock and trauma patients. Next slide. All right, so let's spend some time with cardiac arrest. So there's three big things, three main reasons why we monitor end-tidal CO2 during cardiac arrest. This is something that's a very commonly accepted practice. ACLS talks about it. So the number one thing, and we talked about this already, is we're confirming and monitoring artificial airway placement and the continued patency and position of that. So it's for newly placed airways and, like I said, to verify existing ones that have already been placed. The next one is to assess the quality of chest compressions. So end-tidal CO2 and capnography is an indirect measure of blood circulation with chest compressions. And that's, like I said, your cardiac output is tied directly to your end-tidal CO2. So it's a good gauge when you're looking at that. There's a lot that you can tell just looking at the waveform to know whether the chest compressions that we're doing are effective or if they need to be changed. Either sped up, slowed down, greater depth of compression. So there's a variety of things it tells us. Normal cardiac index, and cardiac index, again, it's a calculation of your cardiac output and the patient's body surface area. So it's normally 2.5 to 4 in an adult. End-tidal CO2 is normally 35 to 45, like we've said. During CPR, you're aiming for a cardiac index, this is kind of typical. 1.6 to 1.9 gives you approximately an end-tidal CO2 of 20, which is kind of that target range of what you want to maintain that number above when you're doing chest compressions. So in ACLS, high-quality chest compressions, again, this range varies. They say 10 to 20. Is that your observation too?
Mhm.
But I think that a number...
Less than 10 is you have to do better compressions. That's the key number there.
Yeah.
Less than 10.
And I know that there's been studies that have looked at ROSC and where you gain ROSC and what the average value is somewhere around 25. So there is some question as to whether the ACLS guidelines kind of undershoot what you're aiming for end-tidal CO2. That slide above, when you look at cardiac index and the correlation to that 20, if with an end-tidal CO2 of 10, your cardiac index is a lot lower than that. So I do think that there's some questions surrounding that and whether that's an appropriate
I think there's
value
a
to target.
variability
Yeah.
in all of those numbers in real life.
Mhm. Yep, and then we also talked about this, so the quality of CPR, so it deteriorates with compressor fatigue. And I wish I had a graphic that showed that too, but typically what that looks like on the waveform when you're monitoring it, your waveforms will look nice and normal, and then you'll start seeing them take on the same shape, but start to decrease in amplitude and height. And usually that means that chest compressions are not effective. Next slide.
I think I've thought before of like watching the waveform, but I've never thought about the depth or the height. So that's
Yep.
a good, for the fatigue. That's an excellent.
And those are things on average, I do think it's an opportunity. It's the technology exists there to help us make those determinations, and it's just a matter of understanding and just taking advantage of what we have. So, okay, then we talked about ROSC. So it does help us to predict and identify return of spontaneous circulation. So an abrupt and sustained increase in end-tidal CO2 equals an increased cardiac output. Like we said, they tie hand in hand, so it's indicative of ROSC. So that waveform on the right is what you would typically see, and I think that there's also an example on this sheet of what that looks like, but you typically have waveform depression followed by an abrupt spike up to a waveform that looks more normal. And when you see that, I think the wisdom in ACLS is know that when you see this happen, you're likely to feel for a pulse at the next interval and have a pulse. But I don't think that they tell you when you see this to interrupt chest compressions.
Correct. You need to continue through your 2-minute cycle before you check a pulse again.
So just be mindful. If you see this happen, continue your chest compressions, but anticipate if that's sustained at that end of that 2-minute cycle, that you may have a pulse. And then so studies indicate that an average end-tidal CO2 after ROSC, with ROSC after CPR is around 25. And then this is what Julie was saying. So end-tidal CO2 of less than 10 for greater than 20 minutes is predictive of non-survivability, and you should consider terminating efforts after that. So. All right, so we talked about documentation. This is important. So documentation on the code sheet. It should be assessed and recorded during a code. So code blue, code white flow sheet with every vital sign check, and Julie said every 5 minutes. We talked about this as well. Respiratory therapist managing the airway should call out confirmation, either by calorimetric monitoring or by waveform capnography. But again, if the RT is not in a position to be able to visualize that, help them out. It's a team sport at the end of the day, and if you're the one who's recording, then we still need to make sure that that gets done every 5 minutes, and that's on the sheet. Next slide. Thank you for helping me with that, by the way. It'd be hard to like walk back and forth throughout the whole thing. Last thing is, so if there was something that I didn't cover in this presentation, you want to know more about end-tidal monitoring and waveform capnography, I just did a quick screenshot of what's online if you go into HealthStream. So all of these modules exist here for looking at capnography and end-tidal CO2.
And
Lots of different options.
Is the stuff that you covered today covered in most of those, like in particularly that congestive heart failure and COPD? That
I'm going to
looks
feel
like-
terrible saying this, but the reality is I haven't taken any of these.
So you don't know.
So I'm not sure what they encompass. Has anybody here
No.
done any of these modules?
I haven't taken all of them.
Okay.
I think they're different bits and pieces of everything that's been in here.
Okay. So I'm not sure how extensively
Right.
it's covered, or if it's just kind of the basics of it. But yeah, these are some options for capnography. Should you be interested in diving into it a little bit more?
Each of them are an hour, so.
Yeah, it does look like a couple of these award continuing education, maybe, right? All right. I think that's it, actually. I think next was just a question slide. So, do you guys have any questions about anything that you saw in this presentation? Like I said, we're going to move on to the hands-on portion next and go through some of these devices individually. But I don't know if there's anything on that stood out or you have more questions about.
If you can go back to that, next to the last slide about the end-tidal CO2 for more than 10 minutes.
Sure.
Wait,
One more. Yep.
That last one.
Greater than 20 minutes?
Oh, greater than 20 minutes. Oh,
So it's less than 10 for greater than 10
Okay.
minutes.
So that's the importance of making sure that gets on that down here.
Yeah.
So you know how many minutes it's been and determining stopping to go.
Mhm. That's part of
And
it.
that's just one factor. That's,
Yeah,
because there's many factors.
sure. Okay. Could we get like a copy of this PowerPoint?
Yeah, I
Okay.
can send it to you.
Yeah,
'cause I added
and we
one more
can send
slide
it to
today, but,
every single person who's here.
I need one anyway for the health stream.
Okay.
This is gonna be so valuable for the floors.
Yes.
So this will be available on HealthStream too.
Okay.
So they'll
This
be- they'll be able-
particular presentation?
So
I guess I'm
it
on
will-
camera, so.
Yeah, so it'll go on the educational
actually.
channel, the
Yeah.
YouTube channel, and then you could, so by the end of next week, I'll have the course built in HealthStream and
Perfect,
you'll be
thank
able to
you.
access it, yeah.
So, and if you think of any other questions along the way too, I attached my email address to the last slide there too. So feel free to call or email me if you think of anything else that I didn't cover or that you think of.
Wait, no, go back.
All right. So I think we have about 10 minutes remaining to play with all these fun things that we brought. What do you want to start with? Should we look at some of the non-invasive stuff first? And then-
Yeah, let's just go across the table
Okay.
and come on up and over. We'll start with the, oh, I don't know.
Which one you want?
Everybody.
Yeah, I changed the code, I got in there.
All right, let's turn this guy on.
Yeah, I don't know why that wasn't working, but I reset it to that number, so.
Yeah, I think we're good.
We got it.
Thank you.
You want me to keep recording this?
Now, actually, was there anybody signed in?
No.
Then no. Thank you.
You're welcome.
He's getting started.
Okay. Sorry, I'm trying to get this to a spot.
The
that's good for
little
everyone.
cameras on.
Just
Unfortunately with this, it's going to be hard to get into a spot.
I was
where
curious, what part of the
everyone
country are you from?
Louisiana.
Okay. My mother's family was from the South and Tennessee. I'm like, how should you get the Tennessee accent? Just, you two drive me
People
crazy.
in orientation 50 and nurse.
can see. Okay, so these are the nasal cannulas that we have. So you'll see this oftentimes on the floor. We use it in the ICU as well. But this is a non-invasive way of monitoring end-tidal CO2. So just kind of the anatomy of this device. There's different products, and they do slightly different things. This particular cannula that we stock, one side of this, so there's one prong that provides oxygen, and if you were to hook this up to oxygen, it would attach to right here. You run your line to that and into the flow meter. So one side supplies oxygen, and the other prong supplies
send you the link.
monitoring for the end-tidal CO2. So there are products that
Do you wanna
provide
make sure
oxygen and monitoring through both of these prongs, but ours are only the single one. This little thing on the end that looks like a beaver tail, it's called a scoop. I just learned that yesterday. The actual, one of the reps was here yesterday talking to us. But when you look at this, it's not actually full and squishy. When you turn it around to the backside, what that does is it's monitoring exhaled CO2 through the mouth. So if a patient is a mouth breather, if they're not, breathing in and out through their nose consistently, it's still going to pick up carbon dioxide coming from that scoop area.
Okay, now you said one side was for the oxygen, the other side was for
Yes.
the monitoring.
Yep. And so if I put this
So
in,
if they're mouth breathers, they've had that before, and put the oxygen like right here.
Yeah.
So is it actually picking it up?
Oh.
so you can see sort of like with it on me now,
Mm-hmm.
you can sort of see where that sits in my face. So it's not like a perfect system.
Right.
Like so if I'm talking, it's probably, I can't see what the value is, but the value would probably be lower if I talk than if I'm breathing in and out through my nose.
Try holding your breath.
See how high I can get before I pass
That's going
out?
up. Very good. You're not good at
Now hyperventilation.
Okay, there it goes. Okay, now.
I'll probably get into the 20s, but yeah, so anyways, that's how that works. I don't know if you have any questions about that device, that's pretty straightforward. And that noise that you hear, so do you guys hear that clicking?
Yeah.
That's the drawing of gas up into that to be sampled.
Oh, so that actually tells you that it's working?
Yeah. And you'll hear it
So
making
when
that kind of
Kathleen
clicking
asked
noise.
you, put the prongs down here for mouth breathers,
Mhm.
will the scoop catch enough end-tidal CO2?
If you have it in their mouth, I'm thinking it's going to be sitting sort of, if you actually have the prongs in their mouth,
Uh-huh.
the scoop's probably going to be sitting below, so I'm guessing it's not going to be as effective.
Right.
But it's
Okay.
not and unfortunately, it's just not a perfect measure, but
I mean, just we have that problem with COPDs.
We do.
You know, and it's like, what do you do to actually be able to monitor it, because it's important enough to look
Well, I
at
wonder,
that.
I mean, there we could put a real cannula in their mouth and then
But
this
that is what
one
we
here
do. Now,
and
if
put
you,
the scoop over
we
the
do, we'll
mouth.
put it in their mouth and
Uh-huh.
then have something
you have
else
two.
over. Yeah, even if it's like a oxy
I'm going to
mask.
turn this off just so it
Mhm.
doesn't keep going. Yeah, so there's different ways, again, we're tied to, the devices that we have available to us. There are, like I said, other ways of monitoring that.
Mhm.
And actually if they have COPD and they're on the V60 on the BiPAP or non-invasive ventilation setup, the new circuits that we have, they have an exhalation valve that's built in now that's compatible with end-tidal CO2 monitoring. So in a pinch, we'd be able to attach that to that device and it would work. I think end-tidal CO2 just nationally is gaining more traction just with the value of it that it demonstrates. So I have found that manufacturers are finding ways of providing better measurement options for measuring.
Are you going to be able to add that to ventilators here?
End-tidal CO2?
Yeah.
So we have some that monitor the
Okay.
servo eyes. Some of them have the monitoring capability built in. And then other ones, they have to go through the Philips monitor. But yeah, some of them actually have the ability to adapt end-tidal monitoring directly to the ventilator.
So then it's not the nasal prong, it's like a little attachment
Yeah.
that goes. So if we're having to use the
It's-
Philips, we're still having the nasal prong.
No, you can, so with the Philips, so this is another example. Anything where you see
Oh, yeah,
this kind
yeah.
of like twisted
It does.
adapter.
It hooks.
And the way that that works, if you haven't used this,
Yes, I haven't done.
there's like a little slide. So on this, it's built into the monitor, but the monitors that we have up in the intensive care units are probably down in the ED. It's an actual tram that slides in, but it's the same system. You kind of pull that little door down,
Yeah.
and when you pull the door down, it twists in and just kind of attaches. So anytime you see one of these with that adapter in it, then it's compatible with the Philips monitor. So this would be a non-invasive way of monitoring. This one,
I guess it was just
you can attach to an endotracheal tube also and monitor
I'll
watch
invasively.
for it.
I don't know, Julie, what your thoughts are. I've been places actually where they put these in line with a bag valve mask or providing manual ventilation, have that in there even when a patient's not intubated. So I don't know, that might just be
I've
kind of
heard that it's
anecdotal thing,
effective,
but-
I've heard both. So I don't know what
So
the
you would have
manufacturer
this.
said.
yeah, I mean, if and kind of stick that in between the mask and
Yeah.
in the bag itself, and then hook it up to the monitor. I mean, it will work. I
It'll
just don't know
catch
what the
some.
quality is.
And that's,
I'm wondering, I think we
it's not
might,
as high a quality as being intubated, but you will get some.
and I think we
feedback.
do the nasal. Haven't done a code in a
That's
while.
what
I think
happens
we
in
do
the ER, put the
nasal.
nasal prongs in with
And then
the
you
bag
still
over
do
the
it.
top.
Yeah,
More
but then there's
often. There's a gap then,
Yeah.
because that is
so
coming
this
out.
is, I wonder, it would be nice to do a study to see what's more accurate.
Yeah, and I can't
Yes.
speak to the, like I said, I can't make a recommendation one way or
Right.
the other, but it's just anecdotally one thing that I've seen done places that I've been. So.
Well, it seems like this would be better because you would have a better seal.
I would agree with.
But I don't know how accurate that is compared to the nasal. See, I mean, it's still CO2 coming out whenever you
Mhm.
bag and then it comes back out.
And so here we have the Zoll. We have, it's R Series Plus Zoll. This is our monitor in every clinical place on campus at A&MC. You turn it on to the on position. When you turn it on, it's in the AED function. You're gonna press manual and confirm to get it into the fully functioning capability of this. Then, will you come intubate for me? So we're gonna have the patient intubated.
That was easy.
Wish they were all
And
set.
then, this is the package that you're gonna find the capnostat in.
Put it in front of the, there, down a little, perfect.
There is a clear one, which is an adult for ET tubes greater than 4, and then there's a purple one, which is for infants, ET tubes 4 or less. Where P is for purple, and the difference is it limits the flow, so it's appropriate for the size of the ET tube. So then this patient, I'm going to place it on here. Someone's going to continue to bag for me. And then I'm going to grab the, where did it go? There it is. All these wires. It's real life. And then I'm going to place the Zoll infrared on here. It slides on and it clicks. Then I'm going to go to the monitor. I'm going to press parameter. And then I'm going to press CO2. And then I'm going to enable CO2. And then you'll see it right here in this yellow box. And it'll give us a number. It does have a significant delay of oftentimes at least 2 minutes to get the number to read here. Once it starts reading, it's very instant feedback on what the end-tidal CO2 number is.
Would people think that the placement was not correct if they're waiting for that to come up?
That has been an issue. That's why I make sure to mention that it takes as much as 2 minutes. And then you're also going to want to put an O2 sat monitor on as well, that patient, on the arm that does not have the blood pressure cuff. And then you have both O2 sat and end-tidal CO2 values. It's a cut.